Okay, this is second talk, and thanks everybody for joining the first one. Hope you guys liked it some. Optimal replacement for hypopituitarism. The outline is causes of hypopituitarism, cortisol, the right and wrong way to give, thyroid optimization. We'll talk a lot about desiccated thyroid for essential hypothyroidism. We'll talk about growth hormone, not just for kids, oxytocin, the love hormone, testosterone, not just for men, stimulants to treat pituitary apathy, learn about the common medicine you should never take if you're on growth hormone, and learn how hormones interact. So what's the big deal with pituitary hormone replacement? Pituitary disorders are common, but experts in treating them are not. Many patients with hypopituitarism feel like crap, with weight gain and fatigue, but small changes in replacement you feel can make a big difference in your symptoms. Many endocrinologists do not understand properly how to treat patients with hypopituitarism. They don't understand or they don't believe in monitoring hormone levels. They don't understand that fine-tuning makes a big difference. Some of the extra things that I do, testosterone for women, oxytocin, stimulants, make a huge difference. Most endocrinologists, it's not on their radar. And we just need to do more. I think that's why you guys are here. Patients with hypopituitarism that receive conventional hormone therapy, such as steroids, cortisol, and thyroid, maybe if you're a male, testosterone, you have increased mortality. You don't feel that well. These are just partial part of the problem. At least it was thought that some of this is due to growth hormone deficiency. And now many patients do get growth hormone thanks to the Magic Foundation and others pushing it in most of the literature. But still, there's this decreased quality of life in patients and decreased mortality, and maybe due to suboptimal hormone replacements. You have these axes. Many people know these. The adrenal corticotrope axis starts with CRH in the hypothalamus, goes to HCTH in the pituitary, and then cortisol in the adrenal gland. The thyroid axis is the TRH, goes to TSH and goes to T4, or T3. The gonadal axis, the gonadotropes in the pituitary, the GnRH is made in the hypothalamus, goes to LH and FSH in the gonadotropes in the pituitary, and then goes to testosterone and estrogen in the end organs. The growth hormones are called somatotropes. The axis is the growth hormone releasing hormone in the hypothalamus, goes to growth hormone in the pituitary, and then IGF-1 in the end organs, such as the liver. Prolactin is made by the somatotropes. There really isn't an axis of that. The posterior pituitary makes two important hormones that I think are under-recognized, ADH and oxytocin. There's a distinct order of deficiencies with hormones. It doesn't always go this way, but it frequently does. That growth hormone is the first axis to be affected. Gonadotropins, FSH, and LH are next. TSH is next. ACTH is well preserved. You need to have a lot of your pituitary damage before you get ACTH deficiency. Prolactin is pretty well conserved, and posterior pituitary hormones are also not that often affected, but they probably are more than people recognize. So what causes hypopituitarism? Anywhere along the hypothalamic stalk or the infundibulum that connects the hypothalamus to the pituitary, and microadenomas. Kevin, you and I, it's been about 15 years or so, published an article that microadenomas do give hypopituitarism. So you can have pituitary tumors, macroadenomas, microadenomas, pituitary surgery, pituitary radiation, Sheehan syndrome, which happens after delivery, Simmons-Sheehan's, pituitary apoplexy, hypophysitis, pituitary inflammation, emphysema, malnutrition or critical illness, and head trauma. Stalker hypothalamic problems include craniopharyngiomas, and there's a treatment, CNS malignancies, surgery, radiation, head traumas and accidents, traumatic brain injury is quite common. Probably, several million people in the United States have it. Many of them have untreated hypopituitarism. Infiltrative disease such as histiocytosis X and hemochromatosis and sarcoid, infections, drugs such as steroids are very common to give hypopituitarism, dopamine analogs, somatostatin analogs. So we had published this paper in 2008. We took 38 patients with non-secreting pituitary microadenomas, mean size 4.2 millimeters. They had normal IGF-1 levels, although near the bottom of the range often. 19% or 50%, 19 or 50% of them were found to be growth hormone deficient. They had a higher BMI, and they failed the test we did at that time. It was called the GHRH arginine test. They compared to, so they were more overweight compared to those who passed the test and healthy controls. 19% of 19 patients had at least another pituitary deficiency. So most of them had growth hormone, but they often had another deficiency. And we concluded that a substantial number of patients with non-secreting pituitary microadenomas were growth hormone deficient despite normal IGF-1 levels and had at least one other pituitary hormone deficiency, suggesting that non-clinic secreting microadenomas are not harmless. So many patients have low IGF-1s, and microadenomas are believed are even more likely to be growth hormone deficient. So this is not that rare. Most endocrinologists sort of do, I think, the backwards way. They only look for hypopituitarism if they had prior surgery or radiation. I try to look for hypopituitarism based on their symptoms. I do for most things in medicine. Many of the guidelines don't recommend testing for growth hormone deficiency in patients with pituitary tumors. I was at the Endocrine Society meeting and somebody's talked about the replacement. I said, well, what about looking for growth hormone? They said, oh, we don't do that. The guidelines say not even to do that, in spite of my paper. My approach is to measure pituitary hormones first in patients with symptoms of hypopituitarism. And if it points to hypopituitarism, such as growth hormone deficiency or central hypothyroidism, then I get an MRI. And if the MRI shows a small pituitary, such as with empty sella or a tumor, and the IGF-1 is low, and the patient has symptoms of growth hormone deficiency, then we do a growth hormone stimulation test. Those that fail the growth hormone stimulation test are put on growth hormone. Yes. I think it depends on their symptoms. Near the bottom of the range, most of these patients have their IGF-1 near the bottom of the range. We'll have a slide on that. Traumatic brain injury, again, very common. People are in car accidents, get whiplash, head trauma, fell, things like that, get hit in the head with things. I think a lot of football players have this personally. Symptoms would be fatigue, poor exercise performance, feelings of social isolation, mood changes, lack of motivation, easily irritated, memory and concentration problems. And these they commonly develop these problems after a head trauma. They were fine before. So what happens to the pituitary gland remains in place as the brain moves forward, and then the skull, then backwards with the skull. So you have it's surrounded by this bony area, the sella, that causes micro tears in the pituitary blood supply and nervous system, leading to hypopituitarism. Now, Sheehan syndrome is postpartum pituitary injury due to hemorrhage. Patients would bleed a lot and they get like a very severe headache. Simmons syndrome is atrophy or destruction of the pituitary anterior lobe of the pituitary, resulting in hypopituitarism, not necessarily with hemorrhage. Traumatic injury results in hemorrhage in a non-pregnancy state and can also cause partial or complete pituitary failure. Dahan syndrome, which I didn't hear about, so I made this slide, is pituitary injury due to severe vasospasm without significant hemorrhage. And pituitary apoplexy is an infarct of the pituitary adenoma and intramass hemorrhage with resultant injury to hormone production by the gland. So Sheehan syndrome shows here, it's a fragile blood system associated with postpartum hemorrhage. In pregnancy, the pituitary enlarges due to increased metabolic demands, and then you can sort of like outstrip your blood supply and get a mini stroke. Pituitary necrosis not associated with pregnancy is called Simmons syndrome. In Sheehan syndrome, you have postpartum hypopituitarism due to pituitary necrosis as a result of intrapartum or postpartum hemorrhage causing hypotension. So often the blood pressure is quite low. They have very severe headaches, absence of lactation, amenorrhea or oligomenorrhea, just very light periods or no periods, central hypothyroidism, adrenal insufficiency. In their labs, they have low TSH and low T4. So in conjunction, the two of them makes it look like they have central hypothyroidism, low ACTH and cortisol, low LH and FSH, and low estrogen. Pituitary, and then you want to replace the hormones. Pituitary apoplexy due to pituitary tumor usually has a headache, visual field defects, and symptoms of hormone deficiencies. Some of the symptoms include menstrual irregularities. 100% of them had that. Absence or sparse pubic hair, weakness and loss of weight, dry skin, failure to lactate was common, atrophy of the breast was pretty common, and hypotension. So for people with Sheehan syndrome, prevent with severe headache, hemorrhage, can't lactate, adrenal insufficiency symptoms. May be delayed, although most people seem to remember when it happened. May recover with time. I've had patients that had Sheehan syndrome, and then years later they recovered. And you replace the hormones as indicated, and you have to correct the right hormones correctly, as we'll talk about. Okay, what about glucocorticoid insufficiency? We'll start with the different axes. We'll talk about glucocorticoid insufficiency. It needs a significant impairment of the pituitary function. Classically, the pituitary only affects cortisol, not the mineralocorticoids, which are aldosterone, the salt-regulating hormones from the adrenals. Although I think there is a role for the pituitary to regulate aldosterone as well. It can be life-threatening, but most patients do surprisingly well. Symptoms include fatigue, lethargy, nauseousness, vomiting, joint pains, abdominal pain, weight loss, hypoglycemia, which can happen in adults, so it's what happens more commonly in children, and low sodium. And I see a tetrad of GI effects. These are, I think, are what I call the main effects of hypopituitarism. Hypocortisolism would be nauseousness, vomiting, diarrhea, and abdominal pain. I always ask patients.
Did you say hypo or
hypo? Hypocortisol, glucocorticoid insufficiency. So what I do is I screen with an 8 a.m. cortisol. If it's really low, less than 3, they have clear-cut glucocorticoid insufficiency. If it was greater than, say, 10, and the new assays are more sensitive, so you usually use a little higher value, and they're not under severe stress, glucocorticoid insufficiency is unlikely. And you have this gray zone of sort of 3 to 10, where that's you can do a cosentropin test. Cosentropin test doesn't work if there's an acute injury. You have to have an injury for at least a month. But the cosentropin test is widely done. I think endocrinologists like to do it. It needs to be done in a place that has experience in doing it. No, it's not that difficult of a test. The cosentropin test, the standard one is you give 250 milligrams of IV or IM cosentropin. You measure cortisol at times 0, 30, and 60 minutes. Any value over 16 is normal. They used to say 18, used to say 20. Now they're going down to 16, which I agree with. The assay is more sensitive. If the peak response is less than 10, glucocorticoid replacement is required. If it's between 10 and 16, it's recommended during stress. Otherwise, it's individualized. And due to improvements in the cortisol assay, the cortisol cutoff decreased. Yes, Gina?
-4. And my cortisol was 11.5. So I'm right there in that grade.
Right. So, a lot of it depends on your symptoms and whether you need it or not.
So I take it for stress, and I take it throughout the day occasionally.
Okay.
Like mom.
No, that sounds good.
Some doctors say, no, you don't need it at all. And some say, you need to be taking this 3 times a day.
I think what you're doing is correct. Other tests would be the ITT and meteropone test. These are less widely done. They're non-physiological. They both can you feel lousy after doing these tests. Rarely needed. The ITT needs to require physician supervision, but can be also used to diagnose growth hormone deficiency. Patients often feel bad after the ITT, the meteropone test. Meteropone blocks one of the steps of cortisol synthesis, so you drop in your cortisol by it. There's a company called Alliance that supplies meteropone. The dose is 30 milligrams per kilogram. It comes in 250 milligram pills. So for an average person, you have to go with 11 pills. You measure the 11-deoxycortisol at 8 a.m. and then you give hydrocortisone afterwards because, again, people get adrenal insufficiency in it. And I had one patient I did this on. She really wanted it, showed adrenal insufficiency, and started her on cortisol, and she's doing much better on the cortisol. So.
Growth hormone insufficiency. And I don't know why you put partial growth hormone insufficiency.
So that's probably not the meteropone test, though. It's probably an insulin tolerance test.
Yeah, it was the ITT test.
Right.
And it came back together. They got my blood sugar down to 18, and I ended up feeling. I don't know how I got back to the got back home.
Yeah.
Because I ended up going to.
Right,
the
so
ER
it is a
later that
dangerous
night.
test.
Pardon me?
It can be a dangerous test, for sure.
I ended up going to the ER later that night and
Mhm.
having my first adrenal deficiency.
Wow. Sit a little bit. Adrenal insufficiency is diagnosed if the level of deoxycortisol does not exceed 70 and the cortisol is less than 5. So again, it's not done too frequently, but it is quite helpful for several patients. So how much cortisol do you need to give? When I was at the NIH in 1991, a colleague who I didn't really know, Esteban, measured daily cortisol production rates in normal volunteers using a stable cortisol isotope method. Turned out the average person, an adult, made 10 milligrams per day, 5.7 milligrams per meter squared. And then most of it is absorbed. So when you take a pill of hydrocortisone, most of it is absorbed, but not all of it. So sort of what the average replacement is probably going to be about 12 to 15. Most patients are on too much of it. And if you're on the right amount and you give it the right way, it's probably pretty benign. But most people aren't on that. They're on too much and it's not given the right time. And you want to mimic the circadian rhythm. So the circadian rhythm means what the body makes. Well, the body usually makes cortisol mostly in the morning. So it's usually given in the morning. And nobody can do as well as Mother Nature. Most glucocorticoid replacement is super physiological, meaning doctors give too much. It leads to glucose intolerance, diabetes, increased infections, and osteoporosis. So you want to give the right amount, not too much and not too little. Now, remember what I said at the beginning, ACTH is the last hormone to be affected in pituitary insufficiency. Growth hormone, TSH, gonadotropins are most of the time lost before cortisol. The symptoms of cortisol are also quite unique: weight loss, nausea, abdominal pain, for example. And if you don't have those symptoms and you're not deficient in the other hormones, it's pretty unlikely you have this. You could have this from taking exogenous steroids, but it's less likely to be hypopituitarism. So doctors are quick to jump on giving people steroids, and I think that's a mistake. If you have primary adrenal insufficiency, that's from an adrenal problem. You usually have also like a high ACTH, a low cortisol, a high renin, a low aldosterone. That's also somewhat rare, but it can happen certainly. But for someone to just have a low cortisol, I'd be suspicious before putting them on lifetime glucocorticoid replacement. Once you start somebody on steroids, it's hard to stop. I have too many patients on too much steroids that were put on inappropriately, and not enough patients that are on the right amount.
How can I say with my daughter, she's been on both hormone steroids, and I've asked her endocrinologist, like, is there a different way, or can you give her less? And so I feel like it's making her gain so much weight.
Yep.
And so that's why I came here, I was like, what other way can we go about it?
So it's a fine art to give steroids back, but she should be on the right amount so she's not gaining weight.
How can we figure it out?
Come see me. I don't know. Okay. So if somebody has just an isolated low cortisol, unless it's in the right context, it might be a false positive test. So I always tell people, think twice about starting glucocorticoids, test it again, make sure it's done in the morning because it declines throughout the day, and then the right person should go on it. Glucocorticoids stimulate mood. So most people feel better on glucocorticoids. It doesn't necessarily mean you have adrenal insufficiency just because you felt better. So I titled this section, Cortisol, Right and Wrong Way to Give. Most patients are overtreated. The earliest manifestation of excess treatment is easy bruisability. Weight gain and central obesity also happen. The earliest manifestation of the inadequate treatment is joint pain, GI issues such as the nauseousness, vomiting, diarrhea, abdominal pain. And the GI issues exacerbate the glucocorticoid absorption. So it makes a vicious cycle. Somebody that has low cortisol doesn't absorb cortisol, and then they get even lower cortisol. So the way to get around that is to, you may need to give it by subcutaneous route. In general, I and endocrinologists try to mimic the circadian rhythm with most, but not all, the cortisol given first thing in the morning. Other studies have suggested a higher dose with lower doses throughout the day, often 4 times a day. And I think that's what I do. And most people sort of on this 3 or 4 times a day dosing. You want to avoid large nighttime dosing, as it could relate to sleep disturbances. But I did find when I was at the NIH about 30 years ago, I did a study. You need some glucocorticoids to go into deep sleep if you're adrenal insufficiency. So too much and too little are both bad. But I think some people do need a little bit before, most people need a little bit before they go to bed.
If I understand correctly, I should take, I'm taking like 25 twice a day.
That's way too much.
If I'm having a really fatigued,
Right.
really fatigued day, normally I would say 25 a day. What?
I think 25 is too much. You know, would have to have an appointment with you, but I would say, you know, from most people, sort of between 15 and 20 is sort of the reasonable dose. Maybe some people even less, and then take a little bit at night, spread it out. Yeah. So I usually give most of it in the morning. I aim between 15 to 20 milligrams in a woman, maybe a little bit higher in a man. And then I try to decrease the dose. Long term, you want to give as little as possible. But you want to not have the person feeling miserable, having a lot of symptoms. So many people can get by on less. And as I said, this is sort of the last axis to go. So it's the first axis to recover. You should decrease the dose until some symptoms develop, and then you can go back on that dose. Small changes make a difference, especially between these 15 to 25 milligram dose. That's because of cortisol binding globulin. The cortisol's bound to the cortisol binding globulin and then released from that. So a little bit of change changes the free cortisol a lot. You do want to increase the dose with illness, but I think it's overdone a little bit. Double the dose is probably good. And short term, it's better to give more. Long term, it's better to give less. You could take an extra 2.5 to 5 during exercise. Extra during traveling is probably good. You know, probably just psychological stress, maybe not so good, but stress, traveling is definitely stressful for people. Yeah. Yeah. Right. But maybe you're okay without it. So adrenal crisis is one of the symptoms. GI issues, again, are really common. Nausea, vomiting, abdominal pain, diarrhea, fatigue, low or high blood pressure. Most of my patients come, they say they go to the ER and their blood pressure is high. And the doctor says you can't have adrenal insufficiency because your blood pressure is high. And it actually doesn't make any sense because when you're under stress, you're kicking your adrenaline and you get high blood pressure. Right. A high pulse is quite common. Yes. Right.
So you lose either way.
Right. High pulse, weakness, you feel like you're passing out, you have poor circulation. So how do you treat glucocorticoid? How do you do glucocorticoid replacement? And what do you do if you feel like a crisis coming on? In general, patients on a lower dose, which is what I want to put people on. I want you to be on a lower dose and your daughter to be on a lower dose. You're more likely to get adrenal crises because you don't have this buffer zone, but it's still better long term. So the trick is to be on the right amount. It could be exacerbated by flu or other illnesses. In general, when people have adrenal crisis, you want to try to figure out what is the underlying cause, and is it an infection or some heart issues or something like that. So patients should try to know when it's coming on. They should know about the symptoms. They start with doubling their dose of orals. They can give orals two or three times. Then they can give the IM hydrocortisone, which is called Cortef. It's in an active vial, and it has a syringe with it. It's available for IM injection. They should drink a lot of salt and fluid like Gatorade. They should take synthetic aldosterone, which is called Hydrocortisone. They should have a lot of anti-nauseousness drugs, Zofran and Phenergan on board, pain meds, anxiety meds, like Ativan on board. But people should not be stoic, even though the emergency room doctors usually aren't that helpful, and you just sit there for a long time. You may have to tell the emergency room doctor what to do. On the other hand, you don't want to die from this either. And I've had, unfortunately, couple of patients that have passed away from adrenal crises.
That's my daughter. They're like, what is that? I'm like,
Yeah.
what?
Right.
Here it is. Just give it to her.
Right. So I have, on my website, I have a crisis letter, and people should bring that to the emergency room. High blood pressure.
It's chronic low sodium along with the.
Low sodium, yeah.
I have low sodium and I'm having a gastric bypass.
Mhm.
If I go in and I have a sodium of 130, they say, oh, you're fine, you don't need any
Right.
fluids and.
It could be, but it could be other things.
But I already take 5 grams of salt pills a
Right,
day.
right. So high blood pressure doesn't exclude adrenal insufficiency, and people should have a med alert bracelet that tells doctors and first responders what to do. Most iPhones now have this sort of emergency page on them, so people should fill it there, and I think most emergency, most first responders know to look there. So I have several patients on the subcutaneous cortisol. They have patients that have GI issues, they can't absorb oral hydrocortisone. I usually have them take the solid Cortef. It comes in an active vial, either the 100 or the 250 milligram vial. Reconstitute in 2 mils, so it's 50 milligrams per mil. You can also reconstitute in 1 mil. They have a 250 and a 500 and 1,000 milligram vial. So those are all options. I've switched several patients over to this, and most of them do better.
Insurance will give you all to.
Yes, of course, insurance always gives you a hard time. I dose it usually 3 to 4 times a day, similar to oral, but you can often cut down the dose because it's better absorbed. Some people go on these cortisol pumps, and I think after me, Dr. Midget is talking about that. I recommend this first and mostly this instead. I think it's easier, cheaper, doesn't get infected. You don't have to worry about the different type of pumps. But a few people that probably need a pump like you. The lady behind you on the green. How do you monitor glucocorticoid replacement? Signs and symptoms, you do 24-hour urine for 17-hydroxysteroids. 17-hydroxysteroids are cortisol metabolites. UFC tends to be high during replacement. In replacement, most of the UFC occurs right after taking the cortisol. So the UFC is less reliable than the 17-hydroxys. The lab seems to have trouble doing the 17-hydroxysteroids. The high doses of cortisol replacement, if a person takes 20 milligrams in the morning, exceeds the ability of the cortisol binding globulin to bind to it, exceeds the ability of the kidney to absorb it. So you get a bolus of cortisol into your urine in the beginning of the day. 17-hydroxysteroids are throughout the day, so it's more integrated. So I usually do that to monitor it, although not too many people do that. And there are other hormones that affect cortisol metabolism. We'll talk about that in the end. What about steroid coverage for illness or surgery? Depends on the illness. Moderate illnesses, you can take 50 milligrams twice a day. Severe illness, you're hospitalized 100 milligrams of IV hydrocortisone every 8 hours. Minor procedure without anesthesia, no extra coverage. Colonoscopy, usually double the hydrocortisone and fludrocortisone if you're on it the day before and the day of the procedure. Endoscopy and arteriography, you can do 100 milligrams IV hydrocortisone before and often give 50 milligrams afterwards. Major surgery, IV hydrocortisone before anesthesia and every 8 hours for 24 hours. And then the next day you can double your dose. Yes.
I think for allergy shots, do I need to up dose for allergy shots?
No.
What will it do when I start taking hydrocortisone?
There's a lot of reasons to give you low sodium.
What will it do to my sodium? It will raise my sodium.
Right. So adrenal insufficiency can give you low sodium, but a lot of other things can too.
Hydrocortisone, what will it do to my sodium?
It should raise it.
Start taking
Yeah, it should.
raise it.
Yeah.
But will it raise it sufficiently?
I don't know. There's this concept called adrenal fatigue. I'd say it's mostly fiction. It's widely proposed by alternative and anti-aging doctors, although maybe a little less so. Lots of internet discussion on it, but it may have died down a little bit. It's often based on the salivary cortisol assays called the ones called ZRT. They're both inaccurate. They lack both precision and accuracy. They're marketed to the patients. I did try to call one of them up and try to get some quality control. And as soon as I asked that, they weren't responsive at all. The theory is that stress, quote unquote, leads the adrenals to work harder and make more cortisol. And then it burns out or peters out and makes less cortisol. Dr. Tori Hudson, a naturopathic physician, says it's like a hormone factory, and it wanes in its production. One of the ways it wanes is just by stress. Alternative doctors may give herbs and supplements to stimulate the adrenal gland. There's a product, it's called Isocort. It used to be ground up sheep adrenals. Now it's supplements. I think it's a lot safer. I think with this with less Isocort around, less doctors are doing this. Some of these alternative doctors give hydrocortisone. One alternative doctor said, eat lean, green, and clean is the treatment for adrenal fatigue. I don't disagree with that, but that was part of my last talk. So the facts is that adrenals are upregulated during stress, they're not downregulated, so they don't burn out, they make more cortisol, not less cortisol. There was a paper in Psychoneuroendocrinology in 2006, studying 74 clinically diagnosed burnout individuals compared to 35 healthy controls. They found similar cortisol patterns after awakening and at different times of the day, and after even overnight dexamethasone suppression testing in the two groups. So patients should not be put on cortisol unless they have been shown to have adrenal insufficiency, not just for quote unquote adrenal fatigue. Okay, let's go to central hypothyroidism. It's common, even with small tumors. Mild cases can be manifest clinically. I would say there's more symptoms for central hypothyroidism than subclinical hypothyroidism because the hormones are actually low. In subclinical hypothyroidism due to a thyroid basis, your TSH is high, your free T4 and free T3 are normal. However, in central hypothyroidism, you actually have a low free T4 and sometimes a low free T3. So it's similar symptoms to primary, you're fatigued, tired, weight gain, sluggish reactions, things like that. Most of the cases, the free T4 is low between 0.7 and 1. The free T3 is often unhelpful, but sometimes it can be low also because growth hormone converts T4 to T3. So if I see somebody with a low T4 and a low T3, it's a hint that they might have growth hormone deficiency. Well, most people have a conserved conversion from T4 to T3, and it's usually normal. So the diagnosis is usually made from a low baseline free T4 and TSH. So there's a lot of options for treatment. Levothyroxine, the different brands of levothyroxine include levothyroxine, Synthroid, Levoxyl, Tyrosine, Unithroid. These are all T4 preparations. Levothyroxine is generic. You can have T4 gel capsules, Tyrosine, generic tyrosine, Thiquidity. These are all T4 gels. You can have T3 alone, Cytomel or liothyronine. You can have combinations of T4 and T3. You can have desiccated thyroid, which we're going to talk about extensively, Athesa, Armor, Nature-Throid, WP thyroid, which is no longer around, ERFA. These are from pig thyroids. They're often called natural desiccated thyroid or NDT, or desiccated thyroid extract, DTE. There's Thyroid Gold, which is available over the counter. It comes from New Zealand cows. You can mix T4 and desiccated thyroid and T4. And in general, I would say this is an art. The proper thyroid treatment needs to be individualized, not just one blood pressure medicine, not just one thyroid medicine. Multiple studies have shown that people with hypothyroidism, including central hypothyroidism, on T4 with the proper numbers have poor quality of life. For people with primary hypothyroidism, it's thought to be somewhere between 15 and 20%. So this is a real problem. People don't do that well on T4. And I think that T4, T3 or Nature-Throid is a good solution. The one that you meant Gina mentioned before is WP thyroid and Nature-Throid. They were made by RLC Labs. They haven't been available for about 5 years. I don't see them coming back. So what can you give? Levothyroxine. I think most people do better on this T4, T3 combination or T4 desiccated thyroid. Growth hormone deficiency can lead to an impaired T4, T3 conversion. The T4 and T3 or desiccated thyroid may especially be beneficial in central hypothyroidism. Treating with growth hormone can decrease free T4 levels and unmask central hypothyroidism. But I do recommend, that doesn't mean you shouldn't treat the growth hormone deficiency. So you can have normal free T4, you start the growth hormone, the free T4 goes down and the free T3 goes up, but you should still do both of them. You still treat both the growth hormone. In general, I aim to have the free T4 sort of the upper half of the range, 1.5 to 1.7. The TSH is suppressed. I don't measure it often, but sometimes I measure just to make sure it's not too high. And patients with primary hypothyroidism and central hypothyroidism both, you should also monitor them with free T4 and not TSH measurements. I do. I do, definitely. I do for sure. You want both of them to be mid to upper range.
The person such as myself had lower T3.
Yeah, you should go on be on T3 or desiccated thyroid that raises it.
Well, I'm already on T3. I should up.
I guess so, but you have to work with your doctor.
Yeah.
So Armour Thyroid is the most common brand of desiccated thyroid. It's made by a company called AbbVie. It's a big company. There was concerns about variability in its preparation and lack of standardization, but that's no longer true. AbbVie does a good job with this product. I think it's very pure. MP Thyroid is the one I use the most. It's a brand of desiccated thyroid. It has minimal binders or fillers. Athesa is a new product. What the advantage of Athesa is they test each lot for potency, so you make sure that it's really what it says on it. So it's a good product. I think the companies invest a lot of money into this product. I think it's really improvement. In general, desiccated thyroid has a higher T3, T4 ratio than human thyroid. So when you give patients desiccated thyroid, they often have a higher free T3, a lower free T4, and a lower TSH. But I see less of the low T4 on MP thyroid or Athesa than Armour. So I used to have to give everybody the T4 when I was giving Armour. Now that I give MP thyroid or Athesa, I often don't. Levothyroxine T3 has a short half-life. That means it's gone in your body. So he has to give the levothyroxine, or the desiccated thyroid twice a day. People that give it once a day don't do well. I don't see why doctors would do that, including some smart doctors. It really has to be twice a day. Yes, sir. So primary means your thyroid itself is a problem. You have usually a large thyroid, you have a TPO antibody, your TSH is high. Central hypothyroidism means your pituitary is affected. Most people in this room have the central because they had pituitary problems, and they have a low free T4 and a low TSH.
So
I think lady in the back is next.
why do you need to not eat an hour? Yeah, you take it and then you wait an hour and eat.
Right, so that's probably overblown, but in general, food does interfere with the absorption of thyroid medicine. The tyrus of the gel capsule, it's much less. And I think if you're consistent every day, you do the same thing, you monitor your levels, it's probably not that big of a deal. But in general, it's recommended to do it on empty stomach. Next over here.
So primary Hashimoto's would fall into that.
Correct.
And then what if you had Hashimoto's for a very long time? And then you develop
Right, so you can have both.
Both.
And then when you have both, you monitor the free T4 and sort of replace people like they have central.
If your lab show T3 and T4 in the lower range, and they're still monitoring TSH, do you recommend the twice a day?
Yes, so a lot of times they're all low if they're just given once a day, especially in the morning. People would feel hyper right after taking their pill once a day, and then they feel hypo in the evening and the next morning. You give it twice a day and sort of evens each other out. In general, I would say for central, the free T4 and free T3, you want them sort of mid to upper range. That's more important than having the TSH. TSH is supposed to be low.
Then you recommend, or do you see better results if they go on the desiccated?
Yes, a lot of people do better on the desiccated. For sure, we'll talk about that. Yeah. Yes.
My level 1.19.
Okay. Not bad. Could be a little bit higher. Yes.
A follow-up question to that. My pharmacist told me I can't take my thyroid, blah, 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 blah. Within 4 hours of taking other medication, and once I take it, then I have to wait 2 hours before.
Right. I think he needs to go back to pharmacy school. So, the main medicine, no, it's complete myth. So the main medicine he's concerned about is calcium and iron, and vitamins that have calcium and iron. There's a little bit of concern about the Prilosec, those omeprazole type of medicines. But basically, I think this is overblown. And, if you have a choice, take it separately from food, but I don't think you have to wait up 4 hours. I think an hour is plenty. I mean, if it gets absorbed, certainly within an hour. And maybe it's, even a half hour, it's probably mostly absorbed. Yeah.
Is it normal being central thyroid? I've had PR malformation surgery, I had meningitis, bacterial meningitis. I only produced 0.011 TSH.
Yeah, you have central hypothyroidism.
Yeah.
Okay, so, again, the importance of keeping the free T4 and free T3 in the upper range, the importance of giving it twice a day. So there was a landmark article published by Wang, Huang, from the Walter Reed National Medical Center in Bethesda, which is where the presidents get their treatment from. It's a good place. It was a randomized crossover study. They give 70 patients received either desiccated thyroid or levothyroxine and cross them over. They were supposed to be on a stable dose of levothyroxine, had a normal TSH before the study. 78 patients were randomized, 70 concluded. 35 received armor thyroid at the beginning, and 35 received levothyroxine at the beginning, and then they switched them over. The dose was adjusted so the TSH was between 0.5 and 3. So it was really looking at the TSH. Dr. Wang, Wong, I think it is, really monitors TSH, which I don't think is correct. They continued that dose for an additional 10 weeks. After 16 weeks, they were switched over to the other compound within the same adjustment period and continued for another 10 weeks. So there was not a statistical improvement in symptoms of general health questionnaires, nor psychological testing. There was a trend toward improvement in the group that did the desiccated thyroid compared to levothyroxine, so it wasn't powered enough to show an improvement. It was a fairly small study. However, there was a 2.9-pound weight loss among the group that took desiccated thyroid compared to levothyroxine. That was significant. The patients on the on Armor had a slightly lower HDL, so that could be detrimental, but I don't think that was really substantial. Both total T4 and free T4 were lower on the Armor than on the levothyroxine, because remember I said Armor doesn't have that much T4 in it. If they get NP thyroid, it might be better. So they probably could have done better if they were given a little bit extra T4 or given the Visa or NP thyroid. And the RT3 was higher in the levothyroxine replacement group, which may be detrimental. Most importantly, 49, this is a blinded study. So 49% of the patients on Armor preferred the Armor, 19% preferred levothyroxine, and 33% felt better. So you want people to like what they're taking. That means they're feeling better. So it was a substantially 3 times as many people basically did better on the Armor. So they didn't know what they're taking, and it shows that there was some improvement in how they were feeling with the Armor that wasn't picked up in the surveys. They lost more weight. The people that preferred the Armor lost more weight. They lost 4 pounds on the Armor if they liked it. So those are the people that probably really needed it. They had a better sense of well-being, and their thyroid symptoms were significantly better with cognitive function on Armor compared to the levothyroxine. And this suggests that patients need Armor and would do better on it than levothyroxine. None of them really seem to do poorly. There was a few people, but 19%, 1 out of 5, liked the levothyroxine better. So these people may be poor converters from T4 to T3. They may have high reverse T3. There may be a lot of reasons, but in general, most people did better on the Armor. There was no side effects. There was no increase in heart rate or pulse. They included that the improvement with Armor was not detected by the relatively insensitive methods used in the study. They also included that once a day desiccated thyroid in place of levothyroxine caused modest weight loss and possible improvements in symptoms and mental health without side effects. So my thoughts on this article was that it was a well-designed, well-executed study done with a good group, published in a great journal. I note that they gave Armor as a single dose. Since it has its T3 and it has a short half-life, I think the patient would do much better if they give them twice a day. And I think if they would have done better. So I'm going to talk to Dr. Wang about maybe doing a study with twice a day. He's reviewing right now my paper on reverse T3, so I want to see what he says about that. And this clearly refuted that the Armor is inferior.
Question. You said you're working on that currently, so if we were to switch for, say, my daughter from levothyroxine to this, right now it's only supposed to be taken once until it's approved?
No, doctors can give it any way they want. I think they have to give it twice a day, but there hasn't been a study to prove that. But to me, it makes sense because it has a short half-life, really should be given twice a day.
This was a relatively small study. Though.
Yeah, 70 people, exactly.
Not like 17 panels.
Right, exactly.
How can we get a copy of the PowerPoint?
Oh, here.
Oh, you don't have it? No. Sorry. Thank you. I'm sure.
So a subset of patients did significantly better. And you want to, as a doctor, you want to figure out who's the one should go on this. So as I said, many people on levothyroxine alone don't do well, those people should be offered this as an option, should give it twice a day and should be monitored to see how they do. And I think most people will do a lot better on this. There was also one more thing. There was also, I think, at least seven studies comparing desiccated thyroid to levothyroxine, including the next one I'm going to talk about. Every single one of them showed desiccated thyroid was better, and none of them showed levothyroxine was better.
I'm just curious, so you're the patient who seems to do well on levothyroxine, would you?
No,
introduce this as
not
a-
necessarily. You're doing fine. Don't rock the boat.
Don't broke, don't fix it.
So like I said, 50% of people on levothyroxine aren't doing well. That means 85% are. And, for my county patients, they have so many other problems to worry about. They're fine on levothyroxine, most of them.
I'm just taking it one time a day. When do you do the blood test?
So I don't recommend it one time a day,
Right.
but I still recommend doing the blood test the first thing in the morning before their dose. If you do it after the dose, you almost always have a high T3. Not that high usually, but it's almost always. So I recommend it before, with sort of the caveat that it's going to be a little bit higher during the rest of the day than the morning's the trough. But I usually look at that.
I was waiting till like 1 o'clock to take my second T3.
Right.
And
Or later.
I was in a hospital, the doctor said, no, you don't want it. Now, this is a hospital. They want an endocrinologist.
Right.
He said, no, you don't want to do that. So I always thought I was right.
Right. You were right. He was wrong.
So,
I think he was wrong.
I mean, it was a hospital. I mean, I understand. It wasn't special.
Mhm.
So you take, so if I was taking an EID.
You do better.
Along with my Levoxyl, I would take the Levoxyl and.
Well, the Levoxyl could be just once a day.
Levoxyl and
Right.
the Thyroid in the AM,
Right.
and I would take my second BID at probably 2 o'clock.
Yeah, 2 or 3 is good. Yeah. So my other comments, the study looked at people, all comers, many of them were doing well. As you said, if they're doing well, then don't rock the boat. If they looked at people that were doing poorly, I think they would have found more people. And, people that come to see me, you're not gonna, spend the money to see me. You're used to fly out, it's on Zoom. But if you're doing well, you're not gonna bother with that. So it's really the people that are sick and not doing well that they should go on this. So this was followed up by his colleague, Mohammed Shaker, who's actually an older man and probably nearing retirement age, real nice guy. Published also in JCNM last year. This was a prospective randomized crossover study. 75% of people completed the study. Again, a small study. This one, there's 3 arms, the desiccated thyroid extract, T4, T3, and T4 alone. It was blinded again, which is a good idea. And they were crossed over for 3 arms for 12 weeks and then crossed over. Of the 45% of patients indicated they preferred desiccated thyroid as their first choice, 32% preferred levothyroxine T3 as their first choice, and 23% preferred alone. So again, most people like the desiccated, they like the T4 least. There was no difference on the questionnaires. On some of the other questionnaires also, there was no difference. They also looked at the genetic polymorphism and didn't find any effect. I'll skip a little bit. So in general, I think the studies do show that the desiccated thyroid is more well-liked than the T4. Same thing again, give it twice a day, you do better. Same thing again, aim for the higher free T4 and free T3 and have a low TSH is okay. So in general for T4, T3, this is sort of what you asked about a little bit. First, take the first thing in the morning on an empty stomach, but it doesn't have to be that empty. Twice a day, your second dose mid-afternoon. Avoid taking with iron, calcium, vitamins that have iron and calcium, the protein pump inhibitors like omeprazole, Carafate, Fosfomax, Orlistat, cholestyramine. I would say there's a minor effect of soy. It's probably not that much to worry about.
I take one. Like omeprazole,
Okay.
The proton.
Proton pump inhibitors. Yeah, try to take them separately if you can.
No.
Okay.
It's not going to interfere.
No, it should be okay. Just try to take it separately.
You weigh up.
Selenium increases T4 to T3 conversion and reduces the TPO antibody. There is some selenium deficiency, I think, in the United States. I'm not sure it's needed to measure it, but I think it would be reasonable to take selenium. However, selenium gives you a higher rate of diabetes. So if you have a family history, if you already have diabetes, I probably wouldn't give it if you have pre-diabetes, but if you don't, you can probably take it. Growth hormone deficiency also has a decreased rate of T4 to T3 conversion. So they might benefit from the selenium, but they'd also benefit from being on growth hormone. Okay, next we'll switch to growth hormone, favorite topic here. 50,000 adults in the United States have growth hormone deficiency, so it's a large number. They have increased mortality. It's again thought to be due to growth hormone deficiency. It has a big role. It has decreased bone formation, increased fat, such as central obesity, decreased muscle mass, lipid abnormalities, increased thickness of blood vessels, increased inflammation markers, impaired quality of life, increased number of sick days, impaired exercise tolerance. Most of these abnormalities are corrected by treatment. If left undiagnosed, adult growth hormone deficiency have increased risk for premature mortality, accident for morbidity, and multiple signs and symptoms, including an increase in body fat, a decrease in muscle mass, weakness and fatigue, osteoporosis, increased rate of fractures, dyslipidemia, cardiovascular disease, impaired sense of well-being, such as isolation, anxiety, and depression. Yes, Karina?
My daughter's endocrine actually took her off growth hormone.
Why?
And that was when I think we stopped maybe when she was like 10. So I asked her recently, if we can put her back on it. And she said, "Oh,
Right, now you say all these problems here. So there's two types of growth hormone deficiency in kids. I don't really specialize in kids, specialize in adults, but adults used to be kids. If you have, let's say, pituitary surgery, traumatic brain injury, something structural, you probably need growth hormone the rest of your life. If you just happen to be short and fail your stem test, then you're probably okay once you get older and you're not growing anymore to stop it. So maybe that's her case, but if she has hypothyroidism and cortisol deficiency, then yeah, right, then she probably needs to have her come see me.
the endocrine or my daughter?"
Both, I don't know. Probably your daughter. I don't think I can help the endocrine. It's probably too far gone.
Stop damage, if you have stop damage. I noticed before when I was seeing my hormone doctor, after I had my teaching ovaries son and premature menopause. I was having HR therapy, and I tried some more, and I felt wonderful. I really felt wonderful. And all of a sudden after I started having this central thyroid, the Somorelin does nothing for me, but it gives me a little bit of energy and a massive headache on the second day.
So again, let's focus on things for everybody here. Okay,
So,
no problem. And you can come see me. If left undiagnosed, adult growth hormone deficiency leads to mortality, morbidity, all these conditions here. So most people, I think, need to be on growth hormone against the first hormone affected. I don't see why you could say, oh, these are all the reasons why your daughter should stay on it.
I'm sorry.
Just high cholesterol, you know,
Oh,
yeah.
where were you? Where were you?
Still here, I was always around. This gentleman over here said he heard me talk, this gentleman here, who was it? Heard me talk, one of you guys, yeah, over there, 20 years ago. Magic, so I think I've been speaking.
And I just realized you live in California and I'm in California.
Okay.
Wow.
Doesn't matter, I do Zoom, FaceTime appointments
I'm
anyway.
17, that's-
Okay, so these things are related to growth hormone deficiency, obesity, dyslipidemia, trouble with your cholesterol, impaired glucose, oxidative stress, pro-inflammatory cytokines, endothelial dysfunction. And you're also at a risk factor, more importantly, for heart disease and strokes and blood clots also. So you can't measure growth hormone. Growth hormone is pulsatile. This, you can be at the top, pulse at the bottom. Pulse is useless to measure random growth hormone. People that do it don't know what they're talking about. So you start with an IGF-1. If it's in the top of the more than 50%, it's unlikely. So on average, each lab is different, and each lab is based on your gender and your sex. Let's say greater than 150, give or take. But they have a Z-score. The Z-score is 0, means you're right in the middle. So if your Z-score is above average, your level is above average, it's unlikely. If it's really low, it's likely, and it's sort of in the gray zone near the bottom is when you do the stim test. Especially if you have a history of head trauma, headaches, low blood pressure after delivery, the Sheehan syndrome, history of pituitary surgery, radiation, or pituitary tumor. Those are all reasons to have growth hormone deficiency. If it's really low, like less than 75, it's likely. If it's sort of in the bottom of the normal range, you should do a stim test.
What did you say?
I wouldn't test it at 0. But, it depends on the symptoms and things like that also, but probably 0 would be cut off. In general, I do the glucagon stimulation test. The insulin tolerance test is very hard to do. People feel horrible. The cutoff for the growth hormone, I would say, in both of them is probably 3. Some endocrinologists are trying to say if you're overweight, it should be 1. I think you're overweight because you're growth hormone deficient, I shouldn't exclude it. So I use 3. Sometimes people are at sort of 3 to 5, is sort of in a borderline area. There is a test called a macrolin test. I'll talk about that in the next slide. The macrolin is very hard to get insurance to cover it. It's very expensive. So growth hormone deficiency, the IGF-1 is a screen. It's helpful, but you can see there's a lot of patients in the normal range. There's the women in red and the men in purple, or I guess that's sort of bluish color. There's a lot of people in the normal range and still have growth hormone deficient, and the range goes down with age.
It's not exactly exact science.
No, but it's helpful, but not exactly. So the tests that people do, the insulin tolerance test, the glucagon stimulation test, the macrolin test. The macrolin is potentially the shortest. It might be the easiest, but it's again hard to get coverage of it. They all have side effects, and their in IV ITT is 2 hours, glucagon is 4 hours, macrolin is 1.5 hours. So we do the glucagon test. I think the glucagon is the most accurate. I think IT gets too many people can be missed it. The macrolin, a lot of people have it and miss it. I think glucagon is the best. It's hard to find places that do this. The glucagon itself is quite expensive, so a lot of people don't want to do it because of that. We offer it on Tuesday night and Sunday afternoons. You do need a fast for 8 hours. So I came up with this idea, and I think this is a good idea here. Between cortisol deficiency and growth hormone deficiency, everybody jumps on treating cortisol deficiency, but nobody seems to treat growth hormone deficiency. And like you said, your daughter gets taken off of it. So why would you treat growth hormone deficiency versus risk? You always in medicine look at risk benefits. In growth hormone deficiency, you have symptoms of fatigue, poor sleep, joint pain, psychological issues. It helps with bone density, body composition, carotid intimal thickness, cardiovascular markers, lipids. What's the risk of treating? Not much. You can get joint pain and swelling. It's easy to stop. It's not addicting. On the other hand, cortisol deficiency, mild, yes, you may present a adrenal crisis, but if you're mild, you're not going to get that often. It may help with fatigue, joint pain, abdominal pain, and nauseous and diarrhea. But it shuts down the own adrenal gland from making its own cortisol, making it hard to stop or taper off. And it gives you weight gain, infections, and potentially osteoporosis. So to me, there's a higher risk-benefit ratio of treating growth hormone deficiency in cortisol, but most people feel the other way around. So my approach is to do the stimulation test. You don't need it just for body weight in adults. Oral estrogen, so we'll talk about this a lot, inhibits the action of growth hormone at the liver, leading to lower growth hormone, higher growth hormone, lower IGF-1 levels. Shauna, can I go over a little bit, do you think? Okay. Women need a higher dose. Yeah, I think I'll be okay. Women need a higher dose than men. You start at 0.4 milligrams a day in women, 0.2 milligrams a day in men. You give it at night. The final dose varies. It can't be predicted. Some people need 1.6 milligrams a day. Some people 0.2 milligrams. I titrate based on the IGF-1, titrate every 1 to 3 months. I like it in sort of the upper range of normal, sort of around 200-ish area. And some people, you don't get much better until they're in there. So oral estrogens or birth control pills block the action of growth hormone at the liver. So you get a high growth hormone, a low IGF-1. High growth hormone can lead to diabetes. Low IGF-1 is your main problem. You're trying to treat their IGF-1. So I would say you should never use oral estrogens or birth control pills in somebody with growth hormone deficiency. So I try to treat people with growth hormone deficiency with growth hormone. However, there's a lot of shortages nowadays. Insurance companies can be quite difficult. It's not as expensive as it used to be, but the insurance companies are still being very difficult. And then if you have a shortage and you have the pharmacy benefit manager wants you to be on one growth hormone, but that one's out, it's very hard to switch to the next one. You think they would automatically substitute it, but they don't. And they play a lot of games with you. So there are some cash pay options. The one I use the most is called Zomactin. It's from University Compounding Pharmacy or Ocean Breeze Pharmacy. It's about $250 a month, not too bad. They use different amino acid blends. I like this supplement called Otropin from Orenda. It's droplets of amino acids by liposomes. I think it helps some. It's not that expensive. Yes, it's a secretagogue. And then there's another one called Cerevital. It's available at cerevital.com or Costco. It's $94 for a 40-day supply. So it's also not that bad either.
In Inland Regional Center?
No.
No, because it's a program that my daughter has. Would they, if they would be willing to pay me go through there, if like insurance?
Yeah, sure. So now there's a once a week growth hormone analog. I think this is also a game changer. It's called Sogroya or Semapacitin. It's made by Novo Nordisk, the same country that makes Ozempic. And it's approved for the FDA for adult growth hormone deficiency. It became available in 2023. It's a long-acting growth hormone. So again, it lasts once a week. It's more stable. And it's a lot easier to take a shot once a week than once a day. So it's really an important one. They did a study with 96 patients. They were very similar in tolerability, IGF-1 scores, and the patients liked it better. What I do is I take the daily dose and multiply by 7, give that the weekly dose. I don't see any reason why you should do something differently, but the company seems to suggest giving less to start with. Almost when I give less, I have to go back to the regular dose.
It's a lot more expensive.
If it's not covered by insurance, but if it's covered by insurance, it's not expensive, and there's much less shortages of this.
My daughter was just put on Wegovy.
Okay.
So do you think if she would have get back on the growth
Yeah.
hormones, then she didn't have to do the Wegovy?
Possibly, sometimes they work well together.
Oh, you could do both.
Yeah,
together?
sure. So with the shortage of the daily, this is a good option here. Okay, now we're going to talk about some of the lesser known hormones. Diabetes insipidus. It's now called arginine vasopressin deficiency because people got confused between diabetes mellitus, which is diabetes, and diabetes insipidus. So the hormone's called ADH or AVP. It's made by the posterior pituitary. If you have a defect in that, it can lead to excessive urination and thirst. And I think there's a lot of cases with this. It's mild, maybe it's not so bad, but you have to wake up 2 or 3 times at night to go to the bathroom, then you don't sleep that well, and then you feel tired the next day. So I think it's worthy treatment. If you have a lot of urination, it's bad for your bladder and your kidney. So I ask people how many times they're waking up at night. If it's like more than 2 or 3, I would certainly test it. Yes.
Is it, how true is it that you have to, because my daughter's on the DAD.
right.
You have to wait for it to, for example, like for her urine to be clear to be able to give her the.
No, so I think that's overrated also. So in general, I give 1 dose at night. It's
Okay.
usually pretty easy to do. I think it's not that hard to give this. I used to think it was harder to do, but most people take 1 pill at night, and the pills I think are better than the shots.
She had her butt, like it had to break. For her
Yeah.
to-
Yeah, so that's usually what happens during the day. You urinate a little bit more. I don't like people to urinate that much at night. I don't want people to wake up. So I usually have them take a pill or 2 at night. Sometimes they take it during the day. You could do a 12. You can look at the urine volume. If it's greater than 3 liters, I'm suspicious. And I do have them do a 12-hour fast, no water. Everybody forgets this. They have a little water in the morning with their pills. Any water makes the test invalid. Collect an 8 a.m. serum and urine osmolality. You can get an ADH level or AVP level. You want to have a high serum osmolality, but that's not really part of the cutoff. I usually use the urine osmolality of 600 as a cutoff. If it's less than that, then it's consistent with diabetes insipidus. Greater than that, it's not. Most of the time, the AVP's level is low, even in normal people. But if it's not low, then it's probably not. They don't have that. You must avoid all fluid and foods. And this is sort of replacement of a formal water deprivation test that people don't do anymore. I usually give DDAV pills, usually at night, to prevent waking up at night. They should have some breakthrough urination, as he said, usually in the evening of the next day. I think it's pretty benign. I think there's probably some other benefits of AVP. It's an important hormone. If you're missing this for your diabetes insipidus, it also regulates cortisol some. So I think this is probably we're going to do some more studies. I think it's going to be important.
Yeah, so if my daughter still, she takes the DAVP in the morning and the night, but I've noticed at night she's still going.
Should
Is
be
that-
the higher dose.
So could you have like different doses?
Yeah, for sure. Again, most of the time I give it mostly at night, because I don't want people to
Like
wake up
higher
to a higher dose at night.
You can take too much of it, which I learned.
You
by
can,
having,
right, so you can have a
like,
low sodium
sodium
fluid overload, right, you can
Okay.
take too much also. Let's go on to oxytocin, it's a famous hormone now, the love hormone, it's made by the posterior pituitary like AVP. It's the only one that we don't really test, it's not or replaced. It has a role, I think we're getting more and more literature on this, bonding, intimacy, orgasm, GI issues, trust, generosity, pain, energy. There is a 24-hour urine oxytocin level available at Meridian Valley Labs. I don't think it's great, but it's probably okay. They don't really give that much information on the quality of their assay. And there's compounding pharmacies that give it. I think it's a reasonable thing to replace if you're low. So I usually do that 24-hour test, give it back. You can give it back by troches or sprays. And many people have an improvement in their symptoms, especially these sort of bonding issues, some weight loss, some joint pains, decreased social isolation. With my lifestyle medicine talk, we talked about how bad social isolation is. So that's a reason to treat people. I found that it increases cortisol requirements a lot of times in people on cortisol. So if you're one of my patients and you want to be on this, let me know.
Is there an age limit?
No,
So you have to up your cortisol.
many times. Be, wary to up cortisol. Okay, testosterone, estrogen, and progesterone. The gonadal axis is GnRH, LH, FSH, and testosterone. Women have lack of ovulation, irregular no periods, hot flashes, poor sleep, infertility, vaginal dryness, osteoporosis, decreased libido, poor sense of well-being. So what do you do if you're trying to get pregnant? First of all, determine if you're ovulating. There's an important test that's underutilized, also called an AMH level. High is good, low is bad, although PCOS patients have a high level, so maybe falsely high. But this is a good test. If it's low, say less than 1.5 or so, it's concerned that your ovarian reserve is not that good. You should see a reproductive endocrinologist. If it's okay, you can probably just try timed intercourse, especially if you're ovulating. If you're not trying to get pregnant, replace your estrogen, you should replace your progesterone. And classically, we're talking you only need to replace your progesterone if you don't have a uterus, but there's a lot of benefits from progesterone. And I think many people should still get it even if they don't have a uterus. It's just they can give back testosterone. I can give back testosterone if your libido's low and you have decreased muscle strength. The best assay for low estrogen is lack of periods or regular periods. If somebody has regular periods, they probably are okay. Regular periods is an early sign of pituitary dysfunction. The famous studies, the Women's Health Initiative and the HERS study, looked at postmenopausal women. The average age for the Women's Health Initiative that showed some detrimental effects was 63. It wasn't 50, and it was using pregnant mare urine Premarin instead of estrogen replacement that we do now by creams and gels and patches. So I think younger women are more likely to benefit this, especially a young person. You're missing your years of estrogen, you probably do better on it and higher doses in a younger person. An older person, less clear. Some people I keep it on until they're 70. Some people I stop at 60, depends on how they're doing on it. And then whether you want to have a period or not, it depends on people's personal preference, but usually younger people want to have a period, just sort of be like your peers. If you're less than 45 or so, it'd be reasonable to have a period. So the choice is Premarin. It's called pregnant mare urine. It's called conjugate estrogen, multiple estrogen compounds. I would avoid that. Oral estrogen, estrase. Again, you have it's not as effective if it's oral. Blocks the IGF-1 effect. Blocks the growth hormone, the IGF-1. Birth control pills I also try to avoid. They also affect your IGF-1. They have high dose of progesterone, low dose of estrogen. I think people need more estrogen. There's patches. I love them. Climera and Bible. The Bible's a little patch. Climera's a bigger patch. Estrogel's quite good. Vaginal estrogen is good. Compounded estrogen cream. Some people like them also. They're compounded. So again, oral estrogen replacement, but not other routes as a first pass effect on the liver. It blocks the action of growth hormone in the liver to raise IGF-1. So you get high growth hormone and low IGF-1 if you're on oral estrogens or birth control pills. That's bad. Raises your sex hormone binding globulin, which could be good because it lowers your testosterone, your free testosterone, but you may not want the low free testosterone if it's already has hypopituitarism. Your testosterone is already on the low side. Studies have shown that the effects of oral estrogens decrease free testosterone levels for up to a year after stopping it. Oral estrogen raise your thyroid binding globulin. It can lead to increase in thyroid hormone level replacement. It makes testing for adrenal insufficiency difficult also, and can lead to what looks like higher total levels of cortisol, even though it's not true, because the cortisol binding globulin is affected. So again, the common medicine you should never take if you're on growth hormone, estrogen or birth control pills. What type of estrogen is best? There's 3 types of estrogen: estrone E1, estradiol E2, and estriol E3. Estradiol is the most abundant. There's slight evidence that the estrone is detrimental. Oral estrogens can get converted to estrone, so that's one of the reasons to avoid oral estrogens. I often use the Vital Dot Patch or estrogel. Titrate the estradiol dose. Again, I think it's important to monitor your blood tests as well as your symptoms. We like the estradiol level to be in the 50 to 100 range. There are compounded ones. Compounding pharmacies make Bi-est, Tri-est. I don't really like the compounded ones as much, and the Tri-est has estrone in it, which is detrimental, so I wouldn't recommend that. Generally, try to give a higher dose for the younger patients. Should you take progesterone to get a period? You can either take Provera, 5 to 10 milligrams, it's synthetic, or Prometrium, which is bioidentical, for 10 days. It will usually give a period, unless you're quite low. If you take a daily dose, you usually don't get a period. If you take continuous Provera or continuous Prometrium, you don't. So women less than 40 or 45, I try to get them to cycle and have a period. Older than that, I usually don't have them have a period. I usually give, certainly if somebody with a uterus, they need to take progesterone. Sometimes without a uterus, progesterone may help with sleep, hot flashes, but could give fatigue and bloating, but it's usually not that much with progesterone or Prometrium, more with Provera. Okay, we'll go on to testosterone, not just for men. The physiological role of testosterone is understood in women. There's been very few studies, including that we started a study, we didn't finish it, but it seems like there was some effect of testosterone on sexual function, sense, and well-being, and variable effects on sort of bone issues. In general, there's thought that androgens improve sexual function, improve bone density, improve muscle mass, improve mood and sense of well-being, improve cognitive function, ameliorates autoimmune disease, ameliorates premenopausal symptoms, and improves dry eye syndrome. The detrimental effects or adverse effects could include virilization, including enlarging your clitoral size, hirsutism, which means extra body hair, facial hair, acne, effect on plasma lipids, and effect on behaviors. So a prior study that women with hypopituitarism could have increased cardiovascular disease. This could be associated with testosterone deficiency in women, that these persist after normal treatment. Karen Miller did a study with women with hypopituitarism. They had low levels of both androgen and ovarian production of androgens. They had lower testosterone and DHES levels than if they just had an ovarian failure alone. And Dr. Miller did a study on replacing testosterone, and the patients did in general better. But even she doesn't really recommend it for patients, even though it showed some positive effects. So I recommend measuring a bioavailable and total testosterone level in women with hypopituitarism. If the bioavailable is low, less than 2, I recommend testosterone cream from a compounding pharmacy. It's not commercially available, although some companies have been working on it for a long time. Usually use the 2.5 milligram per ml dose. I start in older women, I might give 1.25 milligrams. Side effects would be facial hair, acne, and hair loss, but it usually works out well. Some people, it's expensive. Some people try to do the subcutaneous shots. It's harder to do that. You have to give a real tiny small amount of that. The dose is very low. And I try to aim for this bioavailable testosterone to be between 3 and 7. What about DHEA? There's also confusion on this. DHES is what you measure. DHEA is what you give. You give adrenal androgens. They're often low in hypopituitarism. I often give a dose between 10 and 25. It may help with energy. Side effects include oily skin, greasy hair, and I find that testosterone in general is more effective than DHEA, but some people do better with both. Okay, next we're going to talk about stimulants, and this is again, glad people are staying. It's the most important part of the talk. There's this very nice article called "Apathy and Pituitary Disease" that has nothing to do with depression. Increasingly, patients with pituitary disease are evaluated and treated at cancer centers. In many ways, these patients resemble other brain malignancies, although the majority of adenomas are benign. The physical, emotional, and cognitive changes that these patients have are on their well-being is malignant. It went on to say there's a greater understanding that these patients may have emotional problems as a result of tumor. The authors present a series of cases in which pituitary disease were diagnosed and treated for depression, showed little response to treatment for depression. When the treatment of pituitary apathy syndrome was considered and implemented, including stimulants, there was a big improvement on apathy, and the hypothalamic pituitary organs improved. So this is, I thought, a very important paper, came out in 2005, showing that you can need to diagnose pituitary apathy and treat it with stimulants. So pituitary apathy means no interest in life's pleasures. Most hypopit patients have this. I think it's very undertreated. It's not really depression. They're not sad. They're not crying. They're not blue. They're just apathetic. Football players have this. Junior Seau committed suicide. Probably had this. These patients respond to stimulants, not antidepressants. I like Ritalin the best. I find it better than Adderall. It's a little more available. I usually give Ritalin LA 20 milligrams in the morning. Many patients do better on this. I think most patients should be on a stimulant. It's not rare. I think most of them should be on this. I've had very few patients that say it didn't help them, and very few side effects, including feeling hyper, insomnia, anxiety. Helps with energy, focus, weight loss. It's really a great medicine for a lot of people. And it's not really that addicting. You can't stop it if you don't like it. There's very few cases of withdrawal. Occasionally it happens that people get addicted to it, including with their family members, but for the most part, it's a good medicine. I think it works. Yes, exactly. Undertreated. This works well with growth hormone oxytocin. I think those together are a good combination. Okay. Yeah, we can go with this. So treating a patient with adrenal insufficiency and hypothyroidism with thyroid medicine without treating the cortisol, you get a breakdown in cortisol. So you do need, if they have adrenal insufficiency and hypothyroidism, you need to treat their cortisol first and then add the thyroid medicine. Treating with growth hormone can also cause T4 to T3 conversion. So you may have to reduce your T3. You may need, if you treat it, then your T3 may go up. So you may have to reduce the dose of T3 if on T3. Growth hormone may decrease TSH. This may mask central hypothyroidism. You may need a higher dose of thyroid medicine once the growth hormone is started. Oral but not transdermal estrogen increase the need for levothyroxine. So if you're on oral estrogens, you have more side effects from that, and decrease the need for growth hormone we talked about. Stopping oral estrogen, raise your IGF-1, so you can have somebody that can get thrown into a crisis because you may get I'm sorry, not a crisis. You may get a high IGF-1 by stopping the oral estrogen. They get side effects from too much growth hormone, like hand swelling, things like that. You may treat adrenal insufficiency and may unmask diabetes insipidus. The growth hormone also causes you to break down cortisol. So it affects an enzyme called 11-beta-HSD1. If you treat a patient with hypopituitarism with growth hormone, you could decrease the cortisol and throw them in crisis. So I had a famous patient that was on glucocorticoids, under replaced on thyroids, not on growth hormone. I thought I was doing her a good deed. I gave her more growth hormone, increased her glucocorticoids, and increased her levothyroxine. A couple of days later, she had an adrenal crisis. So you need to make changes slowly, monitor frequently, see a specialist. So what's the problem overall? Most patients are on too much cortisol, not enough thyroid medicine, not enough growth hormone, not on the right thyroid medicine, not on testosterone, not on stimulants, not on oxytocin. This leads to fatigue, weight gain, and depression. If this is you, get your dose adjusted or come see me, see an expert. I think that's it. Who runs the best pituitary conference? Again, talks will be posted on my website, YouTube channel, Facebook, and podcast.
I have a quick comment.
Sure.
Couple comments. First of all, I've been on bioidentical hormones for
Mhm.
testosterone, progesterone and DHEA for 15 years. I'll be 63
Right,
this month.
right.
And it has been very effective. for
Right,
me, And
yeah.
it's worked really well. And I have, adult growth hormone deficiency.
Mhm. Right.
And I have thyroid, so I'm really pleased. I'm through premenopause and menopause and it's done really well. And I just they monitor with blood labs what I need. And
Sounds like you're doing great, yeah.
it is, it's been very good. I really am thankful for that.
Mhm.
The other thing, when you were talking about, some of the different supplements, and cortisol levels, I have noticed that a lot of weight loss supplements and weight loss medications, but mostly supplements, one of the ways that they're effective is that they reduce cortisol. There are supplements that reduce cortisol, so be very careful when you're looking into things for weight loss.
Mhm.
Because if you have a cortisol deficiency, you do not want to take supplements to reduce them. And so.
So which ones do you think reduce cortisol?
What?
Which ones decrease
I
cortisol?
don't know. I don't know what the supplements are, but I would ask questions carefully before you took the supplement.
So in my next talk, I have a whole 2-page list of medicines and supplements that reduce cortisol. You have it because for testing for Cushing's, but it is true, there's a lot of things that reduce it. And, for Cushing's, it might be good, you want to reduce the cortisol, but for low cortisol, you don't want it. Other questions? Yes,
With growth hormone replacement, is there an age at which you age out for needing it, or is it for the rest of your life?
it's a good question also. So, I give it for the rest of your life. I think there was one study that suggested that people in their 60s or 70s could potentially stop it, but I find those people still benefit from it. You back there? Aye. Uh-huh. Aye. Thank you.
If y'all haven't ever had a talk with Dr. Friedman, he literally saved my life.
Yep.
We flew from South Carolina, California, before he did, telehealth. And I've probably seen like 6 endocrinologists on the East Coast, just trying to have someone close by to do maintenance. Horrible. So
I can attest, I can South Carolina.
Yeah. we're stands for Dr. Friedman.
Thank you.
I used to work for a man who was married to a physician at Tufts. And he told me that his wife said, the number one mistake people make